All right, so now we're moving on to lecture 24. One of the adverse side effects of transfusion is the risk for infectious diseases, all right? And so you guys all probably know all of the donor units go through a infectious disease testing before they're released into the donor pool for transfusion, okay? So we're gonna talk about what type of testing and the testing windows of each of these viruses, what the FDA requires and what the AABB has some published guidelines on. All right, so blood is safer now than ever. If you guys ever heard back in the 80s when HIV became real prominent, AIDS, that's when people became scared of receiving blood products. And it was actually, if you guys remember, his name is Ryan White. He was a 5-year-old little boy. He had hemophilia A, so he had factor VIII deficiency. And you guys know this was before the development of factor VIII concentrate, so he did receive human-derived plasma products. He did contract HIV from a transfusion, right? So a little 5-year-old boy, and this was back before HIV and AIDS was known about, all right? So he scared everybody, kind of like what we're going through with the coronavirus right now, right? Everybody's scared of it, it's unknown. Same thing with HIV and AIDS. He was in school, and when he received his diagnosis, people were scared of him. They didn't want him in school with the other kids, all right? So him and his mom became huge advocates for the HIV and AIDS virus, and it was actually him and his mom. He did succumb to the disease. He passed away, I think, at age 9. And so him and his mom were very huge proactive in getting HIV awareness and changing testing guidelines for blood products. Okay, so his name is Ryan White, if you guys want to look him up and read his story. So that's all about the 80s. And so since then, infectious disease testing for blood products exploded. All right, and so we are continuously adding new infectious disease testing to blood products, the newest one being Zika. All right. So the American Red Cross states that you have a risk of receiving HIV by transfusion. It's about 1 in 2 million. Okay, so it's pretty low. And if you think about the HIV testing, they used to do antibody testing, but the window period was, I mean, months, all right? So the patient could have been exposed months before, but we would not be able to detect it for 6 months later, right? So that's a huge testing. So then the FDA said, well, you can test for the P24, which is an antigen on the internal core of the HIV virus. And so I think that decreased the window to about 25 days, I believe. And so now we are actually doing nucleic acid testing for HIV, and our window, I believe, is 7 days. All right. But there's still a window. There's still a window, that 7-day window there. All right. So however, now that we can do HIV testing by NAT, I don't think any blood donor systems are doing the P24 testing anymore because nucleic acid testing is much more sensitive and specific. All right, so like I mentioned, nucleic acid test has really helped improve our detection of these viruses and cut the window period down. And so nucleic acid is used to detect HIV, hepatitis C, West Nile virus, and hepatitis B, as well as some of the parasites that we're going to talk about. BCOC is one of the newest ones that had been incorporated using NAT, and Chagas as well, I believe. And so here's the risk of transfusion. ABO compatible blood is greater than receiving the infectious disease because of the rigorous testing now. All right, so here's our donor testing of viruses, all right? So hepatitis B and C, and we're gonna, you have to think about how this testing has developed over time. So used to, we could detect the hepatitis B surface antigen, okay? So that's the surface antigen on the membrane of the hepatitis B virus. It will appear before the core antibody, all right? And usually you can see the hepatitis B antigen, we can detect the hepatitis B antigen before the patient is symptomatic, all right? However, the core antibody, the patient is exempting symptoms when the core antibody is developing. Okay. And then we will test for antibodies to HCV. However, nucleic acid for both of these has replaced the antigen and antibody testing. They used to use ELISA for all of these antibody testings. However, now nucleic acid testing is the prominent choice. All right, and if you want to read more about this, the FDA has established guidelines. If you don't have nucleic acid capability testing at your donor facility, then you have to do the ELISA testing to identify the antibody and the surface antigen for hepatitis B, okay? So nucleic acid test will detect your RNA of hepatitis C, the DNA of hepatitis B, okay? And then HIV, we're going to talk about too, and then HTLV 1 and 2, CMV, West Nile virus, and Zika virus. There's some parasites in there too that are becoming more prominent. So one example is Chagas disease. Chagas disease was really only found in Mexico and portions of South America, so only donors from that region was being screened for Chagas disease. However, now with the increased travel, easy travel, the FDA recommends that all donors be tested for Chagas one time in their lifetime, all right? All right, so hepatitis. You guys probably studied hepatitis in immunology, right? Hepatitis A, B, C, D, and E. There's even a G as well. All right, so hepatitis A is usually obtained from the fecal-oral route. It's not routinely tested in our donor population because when you have hepatitis A, you're usually symptomatic. It can be transmitted through a transfusion if you're symptomatic. However, if you're symptomatic, you usually do not pass the physical exam to be a donor. All right, so hepatitis A is typically not a concern for blood products. B and C, we definitely test for. Hepatitis D is a co-infection, so usually it corresponds with hepatitis B. So if you have hepatitis B, you can also have hepatitis D, and then hepatitis E is also fecal-oral route. And so we don't routinely test for that when blood products are concerned. All right, so hepatitis B and C. Like I said, if you have hepatitis A and you're infectious, you usually have symptoms and then you don't qualify for a donor. There's only like 1 or 2 documented cases where hepatitis A has been transmitted by a blood transfusion. And again, no reported cases of Hep E. All right, so hepatitis B or C, you guys all know the patient has liver cirrhosis, will present with jaundice, fatigue, vomiting, elevated liver enzymes. It is a virus. Hepatitis C is generally more milder, and keep in mind, we do have vaccinations for hepatitis B, all right? And so that's something else to keep in mind as well. The reason this is a huge concern as well, because once you are infected with these viruses, you are carriers for life, all right? So even though you might not be asymptomatic, you still can transmit the disease, right? So that's why for these donors, once they are tested positive, they are a permanent deferral, right? And like I said, so nucleic acid, DNA for hepatitis B, RNA for hepatitis C. So we can do the hepatitis B surface antigen. It's the first serological test to become positive. And again, usually we're able to detect that 2 to 6 weeks post-exposure. All right, so there's still that window there of detection that donors could slip through because they could initially test negative. And then the patient will develop the core antibody, the hepatitis B core antibody. So if we were to use ELISA to try to detect the hepatitis C virus, our detectable window is 10 weeks post-exposure, right? Versus nucleic acid testing now 7.4 days. Okay, so that's a lot lower detection window, right? A lot safer products. And then for the hepatitis B virus, instead of about 2 to 6 weeks for the surface antigen, we're now down to about 18 to 18 and a half days. I took this chart from your textbook. I thought it really helped demonstrate what was going on. So here's your DNA test, all right, your detection here. Here's your surface antigen, all right, and then these are the number of months. So notice it's not until between 2 and 3 months that we would be able to probably to detect that surface antigen, and then the core antibody detection would come later, all right? So nucleic acid testing, identifying the DNA, decreases that window of detection, right? So more donors would test positive sooner. They would not be put into the donor pool, all right? And then you have HIV, again, first recognized in the 1980s. And most of our patients that were becoming infected with this disease were those hemophiliacs, the factor 8 and 9 deficiencies that were receiving plasma products for factor replacement. And however, now most of the population that is at risk for HIV are those homosexual men and those that are engaged in needle sharing, right? So those IV drug users. So that's another reason behind our donor questionnaires, all right? We try to catch those donors by asking them what lifestyle they're engaged in, okay? There's actually 2 types of HIV, HIV-1 and HIV-2. HIV-1 is the one that we primarily see in the United States. HIV-2 has been associated with West Africa. However, HIV-2 has been found in the United States among drug users. So that's something to keep in mind, and that's why our blood products are tested both for HIV-1 and 2. So if you think about all the awareness now of AIDS and HIV and testing, the only thing that's a concern for the blood products is that testing window where your donor might have been exposed, but our testing is unable to detect it, all right? So when we identify the antibodies, typically you'll have about 22 to 25 days, all right? So that's your window. Nucleic acid, identifying the RNA of the HIV, 9 days, all right? And depending on what resource you read, it might say 7 to 10 days, all right? So about 9 days is your mean in there. So something you guys need to consider, nucleic acid is the most sensitive and specific way to identify these infectious diseases. However, if your facility does not have nucleic acid, you can still use ELISA to identify the antibodies. And if you have a positive result, then you usually will use Western blot to confirm that, all right? However, usually if you're using nucleic acid, that's your one test. There's no need for confirmation. And then here's your detection time of HIV. And this is the 1. So notice your P24 antigen and then your HIV RNA. So this would be by nucleic acid testing we can detect it sooner. Versus all of our ELISA techniques, identifying the antibodies used to be, see how far out your window was, 50 days, and then it moved to about 35 days. and then 25 days. And so we keep decreasing that window, okay? And I've actually mentioned this before. You will have this happen. So you'll have a previous donor who has tested negative for HIV, hepatitis B, hepatitis C, but then he donates again and he pops up positive. So quality assurance in blood bank is he's now considered seropositive. You have to notify all previous recipients of his units. That's referred to as a look back. You have to document the deposition of all of those units. What happened to those units? Was it transfused? If it was transfused, then you have to notify those recipients. If it was discarded, then it's just documented that it was discarded. No further action is needed because it did not go to a recipient. All right, but if you guys ever receive a product, you sign before you receive that product that you are willing to accept the adverse effects. If you receive a letter from the donor center stating that your donor turned up positive, then you have to get tested as well. All right. And that's for not only HIV, but hepatitis B and hepatitis C as well. All right, so then we have the human T-cell lymphotropic virus, HTLV. This is a retrovirus that causes proliferation of the T cells, and it's actually associated with T-cell lymphoma. And there's actually two types. There's type 1 and type 2. This virus is primarily found in Japan, sub-Saharan Africa, the Caribbean, and Brazil. So some of South America is starting to see this as well. However, HTLV too, it has been documented in the North America as well. So we will test for these antibodies to HTLV 1 and 2. So HTLV can be transmitted sexually or parenteral, so meaning through mom to baby, breastfeeding, needle sticks, needle exposure, all right? And this was actually first found, testing began in 1989. And then all our donors are tested for cytomegalovirus, CMV, which we've talked about before, common viral infection that about 70% of the population is going to have, all right? So your CMV negative population is very low, very minimal. So if any of you guys are CMV negative, your donor facility will contact you and harass you every 8 weeks, okay? It used to be that CMV negative patients, donors, we would use those products for immunocompromised patients, such as our babies, those patients that have received chemotherapy or leukemia diagnosis. Those are our immunocompromised patients. And CMV is a huge concern for them because while it's just a common infection for you and I, for those patients, their immune system is unable to fight it off, okay? And you guys keep in mind too, we talked about this before, CMV negative requirement has really been replaced by leukoreduction, okay? There's some other viruses that can be transmitted as well, such as Epstein-Barr, parvovirus, Rocky Mountain spotted fever. Those are rare instances and they are not actually included in our routine battery of donor testing, okay? Creutzfeldt-Jakob is a concern, not so much for blood-derived products, but for pituitary, any central nervous system, any tissue organ from those, all right? And it's really a concern for the UK, all right? So the European. We don't really do any active testing on our blood products for Creutzfeldt-Jakob, but we do have questions that are geared to catch those, such as if you have lived over in the UK for a period of time. West Nile was one of the most recently added. There were 23 cases of transfusion transmission in 2002. So since then, nucleic acid testing has been incorporated to detect the West Nile. Creutzfeldt-Jakob disease that we talked about. The thing about the Creutzfeldt-Jakob is that it has a prion that makes its transmission. And usually in the US, again, not a huge concern for blood products, usually about 1 in a million. And again, it's those growth hormones from the human pituitary. Again, not a concern for blood transfusions. Bacteria also, and you guys all know that platelets are the #1 product associated with bacterial contamination. So actually, platelets are the only product during the donor collection process that will be cultured at that donor facility. They will do a culture on the platelet unit, all right? There's actually a new procedure that is actually in FDA clinical trials right now, and the Arkansas Blood Institute is actually doing this, and we will talk about it in an upcoming lecture. So think about the expiration time of your platelets. What's your expiration time of platelets? 5 days. So Arkansas Blood Institute is doing a procedure where they are culturing their platelets at the 5-day mark, and if it's negative, they can treat those platelets and then extend the expiration time to 7 days. All right, so we'll talk about that in an upcoming lecture as well.
From the end of that 5-day period?
So it's still from the date of collection. So that gives them 2 more days to transfuse that unit. And we've talked about bacteria. It could cause a febrile non-hemolytic transfusion, stop the transfusion, culture the bag, obtain blood cultures. We talked about examining the color change, presence of hemolysis, any turbidity or precipitate that looks like the cells or platelets are sticking together. And it's very important we can prevent this by following aseptic technique and maintaining the closed system. And that's one of the reasons that we want to know how that donor is feeling that day and if they're on antibiotics. So you see how all of these adverse reactions, infectious disease, kind of guide our questions. So that even comes into play too for autologous cases. So there are some documented cases of sepsis occurring from an autologous, and that's probably due to the collection process. All right, so there's some other organisms that are concerned. Malaria is the most common parasitic infection in the US from blood transfusions. Any component that contains red cells can transmit malaria. And Plasmodium species can actually survive at 4 degrees for at least a week, okay? So even if you have a malaria donor that makes it through the donation process and that unit is stored on the shelf, it could, for a week, that organism could survive. So we don't actually have a current test to detect malaria. So if your donor is asymptomatic, then that unit could potentially make it into the donor pool. That's why our questions ask about their travel history. Have you been anywhere that is endemic to malaria? And if you have traveled somewhere, a malaria endemic area, then you were deferred for 1 year. If you live there, you're deferred for 3 years, okay? Babesia, caused by Babesia microti from the infected deer tick, found in the northeastern US. There have been some documented cases of this being transmitted. The symptoms are usually chills, headache. Some might even cause hemolysis. There used to be no specific test for diagnosis, so they would wait until the recipient popped up with symptoms and then treat it. However, just in 2018, the FDA approved 2 tests for screening of blood donors, and they could use fluorescent immunoassay if you don't have nucleic acid testing, but nucleic acid would be the most sensitive option. And then syphilis. Syphilis was actually one of the very first diseases that blood products underwent for testing. And again, the organism can't live at 4 degrees, all right? Very short lifespan at 4 degrees. So the testing for syphilis, you're gonna do a RPR or VDRL, all right? That is not specific for treponema, all right? You had a high rate of false biological positives, such as pregnancy can cause a false positive, all right? And then, so you would, if you had a positive, you would have to confirm it with one of your microhemagglutination assays, which should detect those specific antibodies. So the FDA has some real specific guidelines on syphilis. If you have a reactive non-treponal screening, so either your RPR or VDRL was positive, but then you had a negative confirmatory test, the FDA mandates that you can release that unit, right? Because there are so many biological false positives for the RPR, okay? Right, and then we have our Zika. It's the newest one added to the battery of testing for blood products carried by our beloved mosquitoes, Aedes aegypti and Aedes albopictus. And I hope I said those right. And we are currently using nucleic acid testing for the detection of Zika. And then here's our Chagas disease caused by cruzi. Again, endemic in the Central and South America. It used to be observed in immigrants, and they used to use ELISA to detect. In 2016, the FDA recommended all donors should be tested once. It used to be only these endemic areas tested for Chagas, and then if you were an immigrant to the United States from these areas, then you would also be tested. However, the FDA has now regulated that all donors should be tested once. So as you can see, these guidelines are always changing, okay? So you can read what the FDA has established guidelines versus what the AABB recommends, but the FDA, of course, has the ultimate say, all right? So there are some methods in place where we can prevent the transmission of infectious disease. One of those is pasteurization, which is incorporated for albumin. Cold ethanol precipitation that used for preparation of some of our immunoglobulins, such as if you were given IV IgG or anything like that. The more we can get away from human-derived products, the less likelihood we will have all of the transmission of all these infectious diseases. And now we know that we can have factor concentrates made from recombinant DNA, which are virus inactivated, whether it be through heat treatment or some type of detergent or solvent treatment. And like I mentioned earlier, no technique that can remove viruses from cells and platelets. All right, so here's a list of all the current testing performed on our donor units, okay? They will have ABO-RH and an IAT performed. What happens if if your patient or your donor has a positive IAT? Should we use their plasma if they have a known antibody? No. All right. So if your donor has a positive IAT, usually we will still use their red cells. You can still use their platelets. However, we are not going to use their plasma. All right. Their plasma is discarded. Hepatitis B and hepatitis C. There's some restrictions there. If you are not performing nucleic acid testing, you must still test for the surface antigen and the core antibody for hepatitis B. All right. However, if you're using nucleic acid test, that is your single test. And we still use ELISA for the HTLV 1 and 2 to identify the antibody. Syphilis, we'll do the non-treponemal test. And then we'll do the follow-up to identify those specific antibodies. We're testing for HIV 1 and 2. Remember we talked about the P24 antigen of the HIV? It's the core antigen of the virus. Used to be that the FDA mandated that you test for that. Now with nucleic acid, FDA says you no longer have to do P24 if you're doing nucleic acid testing. All right, so nucleic acid testing, as you can tell, has really kind of taken over our infectious disease testing. And then the West Nile virus, Chagas, and Zika. All right, those are all the main infectious disease testing that we are doing. All right, so your take home, what all do you need to know from this lecture? You need to know what's the most prominent infectious disease testing on your blood products, all right? You don't necessarily have to memorize the testing windows, all right? You don't have to know that HIV is now 9 days. You don't have to, there's no reason to know all of that. But just make sure these guidelines are always changing. FDA will put out an announcement couple times a year that they've made some suggested changes to their guidelines. Right? And if any of you guys are involved in this and you get active in this, the FDA will put an announcement out for these changes. They will actually take comments on those changes. So if you agree with the changes or disagree, and you want the guidelines worded a different way, you can suggest comments to them and they will take those. So you can do that as well. Sometimes they do. They'll usually send it out to all blood banks, all donor facilities, and then of course they have a period where you can submit suggestions, comments, concerns, and then they'll close the comment time, and then they'll make revisions, and then they send out their full announcement, the official guideline change. Right.